For someone with, I guess, calf tightness, previous calf pain, maybe Achilles pain, maybe plantar fasciopathy, shin pain, we kind of want to be above 6 mil heel pitch. So we want to avoid a shoe that's too minimal, where it's got no sort of heel height to it. And we want to be in a shoe that has a bit of heel pitch to reduce the strain and the loads on those areas. When it comes to red flags, I'd say...
Hi guys, and welcome back to the podcast. I'm your host Indira, and today I'm delighted to bring to you a podcast on all things feet. I'm joined by an Australian Podiatrist of the Year with an endorsement in scheduled medicines, Keain. Joe has a wealth of experience dealing with runners and athletes and working in the field of podiatry. If you don't know what podiatry is, well, it concerns everyone. It's all things the lower leg down and feet. And in this episode, we discuss how to care for your feet, how feet can impact running, shoe choice, injuries, and in particular, we dive into some of the big three: shin splints, plantar fasciitis, and a range of Achilles issues. Lots to learn from and lots of thought-provoking ideas discussed in this episode. So let's get straight into it and let's make sure that your feet won't be causing you any problems to come. Check out the link down below to find out more about Joe and what he does. And if you're lucky enough in Australia and want to see him, then you can find all the details down below. Okay, let's do this. Joe, how are you? And welcome to the podcast.
I'm good, thank you. Thank you for having me.
No, absolute pleasure. I mean, something new. We haven't had podiatry on the podcast yet, but such an important topic. So do you want to go right ahead and introduce yourself? You know, podiatry, what is it? What is it that you do?
So as podiatrists, at least here in Australia, it is a bit different depending kind of where you study. But here in Australia, we deal with everything from the knee downwards. So shin, ankle, foot pain, and we specialise in the foot. So we spend 4 years at uni studying the foot specially. We deal with a lot of sporting injuries, skin issues, toenail issues, potential surgeries, that kind of stuff. So yeah, anything foot ankle related, come and see us.
That's such an important one for runners. I mean, there's just a whole host of issues that stem from the foot upwards, shins. Is shin splints something that comes under your remit then?
Very, very common, yes. Shin splints is actually the reason I became a podiatrist. So when you finished year 12 here, which is like end of high school, wanted to be a physiotherapist. Didn't quite get a high enough score in year 12 to become a physio. Missed out by 0.3%, which was very frustrating at the time. Did like a health science course for my first year of uni and thought I'd just transfer with my grades the year after to physiotherapy. And coincidentally, during that year, I lived with physios and I didn't really like what they were studying. And at the same time, got a really bad case of shin splints. Couldn't run for 3 months, couldn't walk for more than 12 minutes without pain. Went and saw a podiatrist, got orthotics. Within 2 weeks, I was running pain-free again. And I was like, that's pretty cool. And it's kind of like physio, but it's kind of foot physio. And so, yeah, swapped into podiatry the year after and haven't looked back.
Gosh, wow. I mean, that's incredible. You know, people kind of continuously hit the wall with something like shin splints, and to kind of have that gone with just something as simple as a pair of orthotics, that is really quite a game changer.
It was great. And look, not to say every case of shin pain goes away within 2 weeks with a pair of custom orthotics. There is a nuanced approach. A big part of that is load management and, you know, footwear, biomechanics, strength, that kind of stuff. But for me personally, with the way my feet are and the way I was moving, it was a pretty quick fix, which I was grateful for.
Yeah, definitely. I mean, was there anything aside from, I guess, that revelation there that put you off physio as well? You know, maybe just seeing what they were studying?
They, in their first, I guess, year of physio, they did a lot of with like neuroscience and pain. And I just didn't like the pain science part of it. Like I thought, I just want to go in there, work with sporting teams, work with runners, do a bit of hands-on treatment, get in the gym. And they didn't do a lot of that in their first year. And look, university in the first year is always a foundation, right? And it was podiatry too. But I just thought, I don't really want to do that. Podiatry sounds kind of cool. I can do a bit of other stuff too, some surgical stuff, some, you know, on the tool stuff. And yeah, wasn't a huge thought process either. I was only 19, so I just swapped over and kind of went with it.
Yeah, no, absolutely. No, that's really interesting to hear because I think everyone's heard of a physiotherapist, but podiatrist is often maybe not known about or something that people might not consider as a first instance. But it sounds like it's got maybe a lot more immediate action and kind of can have quite a lot of impact and is a lot more specialist than maybe physio, which is actually an incredibly broad discipline.
Yeah, because we work with physios, we're physios in all our clinics. And what I say to them is, I'll handle knee down and you guys can have the rest of the body. So I think that's pretty fair. But with podiatry too, I think there is a bit of a, podiatry is seen sometimes as we just cut toenails. And look, there are some podiatrists that do that, and that's fine. That's our bread and butter. It's just not me. And so I think as a podiatrist and your career, it's what you make of it. And I choose to work with a lot of sporting clients, work with MSK, work with biomechanics, and that's what I love to do.
Yeah, well, don't go to Joe for toenails, guys. It's only proper sporting injuries there. And I guess then, before we dive in a little bit more, for anyone listening, particularly maybe a female runner, why should they keep listening to this episode? What has podiatry got to do for them potentially?
So when it comes to females, and especially podiatry, foot pain and running, there's a lot of changes obviously a female body goes through that's different to a male. So when they're younger, they tend to hit puberty first. So they can develop things like severs, which is heel pain, a bit early in the boys, maybe when they're 8 compared to 10 when they're boys. So they get that pain a lot earlier, which can impact performance and running and pure enjoyment of being out there and moving around. And then we get on to pregnancy. There's hormonal changes in the body. We get things like ligament laxity. We get rapid weight gain, which affects the foot. It can make it harder to exercise and then harder to come back to exercise after you give birth. So it's not an instantaneous, I've given birth and I've lost that weight and now I can go back to it. The hormones in the body do hang around for up to 2 years after birth. And so they can still affect the feet, not only with, the way the feet have changed in structure with ligament laxity, but there's also a lot more sensitivity through tendons and plantar fascia, and things can become a bit more sore with activities that weren't sore previously. And then later on in life, they get menopause, perimenopause, and all those changes can happen again. And that can last for years. So there are a lot of things that happen to women with their feet and when they run that don't necessarily happen to men or happen in a bit of a different way. And so it's important that they are aware of those things at least. And if they are having trouble and are in pain, come and see a podiatrist.
Yeah, no, definitely. There's a lot of stuff to get into there. And for sure, it's interesting, kind of that relationship again with hormones and how it affects the body. And I guess, everything starts off with the feet and channels upwards. And I suppose we got onto things with sort of shin splints. And to my mind, shin splints, it sounds like there's little cracks in the bone or something. But what's the relationship with feet and how can that actually impact that specific injury then?
So there's a few ways feet impact shin pain, and there's various types of shin pain, right? The first being just like general shin splints. Shins are a bit sore, doesn't really hang around too long after you stop running. It doesn't plague you day to day. It's purely maybe at the start of the run, maybe the end of the run, depending on when you're feeling and how much you're doing. Then it moves to a stress response where that bone's having a bit too much load put through it. We're not recovering properly, and that can be for various reasons, right? Like we're just doing a bit too much load. We've jumped up too quickly. We're not on the right shoes. We're not eating enough to recover. We're not sleeping well enough to recover. And then that can move to, if untreated and not managed well, to a stress fracture where the bone actually cracks. And that can be a long period off of running and a bit of an extensive rehab process, depending on how bad it gets.
Yeah, no, definitely. And where would sort of orthotics then come in to play with sort of correcting something like that? And I guess as well, for anyone who doesn't know, what is an orthotic?
So custom orthotic is a special insole for the foot made for that person. So the process is at our clinic, we have a Zebras treadmill, which is a pretty high-tech treadmill. It has 7,000 pressure sensors built into it, and we get the client to either walk or run over it. And we take that data down to the exact kilo, down to the exact degree of foot rotation. We use that. We take a 3D scan of the feet with an iPad, and we take some measurements with a ruler and our own eyes. And then we put all of that information into prescription with the shoes they're wearing, the thickness of the material, the angles we want in the orthotic, the material we want to pad the orthotic out, and we build a customized insole for that person for their feet. And so the role that plays with shin pain is a lot of the time it can be due to the way the feet are moving. So a lot of pronation, a lot of rolling at a pretty rapid rate through the feet. And as that foot rolls through when we're running, we don't get great shock absorption. And that shock absorption then has to go through the ankle, through the shin, and create that pain in that lower shin. So orthotic goes into the shoe, helps control how much that foot rolls, and I guess the degree and the speed, and helps reduce that pressure through the shin.
Oh no, really interesting. I mean, I know I've got orthotics myself, but not sure how they help out so much. So no, that's really interesting. And I guess then you talk about sort of pronation. What really does that mean, and how common is it, and why do people sort of end up having perhaps a bit of rolling or uneven distribution of pressure?
So pronation is the feet rolling inwards. So you might see a flatter foot type and that foot moving inwards. Now, I want to be, I guess, clear in that pronation or rolling in is not the devil. It doesn't mean you're going to have pain. It doesn't mean you're going to need orthotics. It doesn't mean you're going to develop shin pain. But for people that are in pain, it's one of the things we can actually work on to reduce that foot posture and that rolling if we think that's playing a big role. And look, custom orthotics and working on the way the feet move aren't the only thing we do. We look at load management, we look at footwear, we look at smart training, we look at other areas of the body that maybe aren't as strong, whether that's hips, glutes, hamstrings, quads, all of those things to make sure we are moving well. We don't just shove a custom orthotic in the shoes, but it is a big part of what we do.
Oh, interesting. So you talk there about kind of looking at the overall picture, maybe working on certain muscles. So I suppose that can help to correct any maybe misalignments of the feet. But then in what instance or at what point do you go, okay, we can't continue to correct anything muscular wise and it is the right choice to go for an orthotic? What would someone who's maybe thinking about perhaps getting some or not sure if they need them need to think about?
Yeah, so I think we obviously do a full assessment when we see someone. And the first thing we look at is the way they're walking. Then we look at the way they're running. We look at strength and mobility through the foot, ankle, knees, hips, lower back. And we put all that together to determine, I guess, why they're getting their pain. If we think foot posture is a part of that, maybe they're not just getting pain with running. Maybe they're getting pain with day-to-day work, day-to-day life. Maybe they've had foot pain as a kid. Maybe there's a family history of foot pain. You're like, my mum has foot pain, my dad has foot pain, my brother has foot pain, I've got foot pain now. And we kind of see that familial, I guess, history. Put all that together and we run it through, I guess, a clinical lens to determine where that person actually needs an orthotic. And look, orthotics are just a tool. We can use them to reduce pain, manage load, help shoes feel more comfortable, whatever it might be. And we use that as a tool with all the other treatments we do, whether that's hands-on, strength training, change of shoes, to make sure that person is feeling better and can perform better.
No, really interesting. And I guess then when it comes to the performance side of things, does having maybe you mentioned earlier sort of different materials, does that impact potentially how the shoe itself might work? For example, if someone's got an orthotic and they're thinking about wearing a carbon shoe, would that potentially change how the energy return is, or how does it interact?
Yeah, it definitely can. And look, it's a nuanced approach. I wear custom orthotics in my carbon plates, which at the moment are Nike Air Fly X% 2. And first of all, they're a pretty narrow shoe. Like to get the actual sole out was a bit of a battle. I've had to grind down the medial side of the inside of the orthotic to get it in. And it does almost make it a little bit more rocky, I think. But I need that bit of support for my feet, my ankles, the way my feet are shaped. And so I put up with a bit of rocky. And look, carbon plates are a little bit unstable anyway. So I kind of knew that going in there. But yeah, it definitely can change, I guess, the feedback and the responsiveness of how the shoe feels, which is why whenever we do an orthotic for someone, we're going to watch them run before and afterwards, and we're going to film it with our Zebras. So the treadmill has cameras at the back and on the side, and we can take a very detailed video, zoom in, zoom out, slow it down, speed up, and look at how we're moving before the orthotic and how we're moving after the orthotic, and get a really, I guess, detailed data-driven analysis rather than just, I think it feels good, but I'm not really sure.
Yeah, definitely. I mean, feels good, but sometimes data can be quite an important side
Yes.
of things. And for people who don't know whether maybe orthotics could be something they need, or maybe they should go see a podiatrist, what could be potential signs and symptoms in day-to-day life that maybe you could do with a little bit of assistance with your feet?
Mm-hmm. So there are a few signs I would look out for if I was thinking maybe I need to go, first of all, to see a podiatrist and maybe look down the path of getting custom orthotics. The first would be any pain over 6 weeks. If it's especially foot pain, whether that's arch pain, heel pain, top of foot pain, big toe pain, especially metatarsal pains through the middle of the foot, or just shin pain in general, anything that's been hanging around for more than 6 weeks is normally considered what we call chronic. And it's not, it shouldn't be there for that long, especially if there was no real event that caused it. If they get a buildup of, I guess, callus, blisters, hard skin in certain areas constantly, that can be a sign that there's a bit of a high pressure area going through there. Another sign could be if they think their feet are changing, whether they think their feet are flattening out, maybe a bunion's developing, maybe shoes don't fit as comfortably or feel as comfortable as they once did. They feel like things are changing. Or if they're just on their feet a lot at work, think nurses, tradies, teachers, on their feet maybe 8, 12 hours a day, depending on what they're doing. And feet are just getting sore and sore and sore, and they don't really get that relief anymore that they once got from changing shoes or buying a new pair of work boots.
Yeah, no, that's great. Yeah, plenty of things to look out for there. And when you were mentioning kind of the list, you said in particular sort of big toe pain. Is there any reason why that might be so significant? I mean, toes sort of feel like small features at the end of the foot, but yeah, what's their kind of role?
Yeah, so big toes are very important. They're the thicker, flatter toe for a reason. We push off them, or at least we should push off them. Now, depending on how you move, your age, your biomechanics, you might not push off your big toe super well. But ideally, the foot is designed to push off that bigger, thicker, flatter toe to propel you forward more easily with more power, more speed. So if our big toe isn't functioning well, that can lead to a lot of other issues, things like arthritis, stress fractures, pushing off other areas of the foot and damaging those that maybe aren't as thick and flat, as strong as the big toe. So we want to be using that as well as we can.
Yeah, no, well, big toes are clearly very important. And are there any sort of exercises or things that you'd ever prescribe maybe to patients who might be suffering with, I know, issues around, say, the use of their big toe?
Definitely. So every patient, every client that comes into our clinic gets some sort of strength program, whether that's, for big toe, for plantar fascia, for Achilles, whatever they come in with, right? But it's tailored to them and where they're at. So it's not a cookie cutter approach. It's meeting them where they are and having an end goal in mind where we want them to be, whether that's, strength, mobility, or performance. So depending on what, injury or pathology is presenting through big toe, it could be like a bunion. So the joint is changing shape, where it's getting a bit bigger through the side there and sticking out. It can be arthritic change, where they're getting joint space narrowing. So it doesn't look like a bunion, but there may be a lump on the top here and it's not bending super well anymore, so we can't actually move it and propel forward. It could be a sesamoid injury, which is like the two little bones on the bottom, where anytime we go onto our toes and push down, say you're pushing off when we run, dancers, going up on toes to get something off the top shelf at home, that just really hurts. And there are various other pathologies around there that, depending on what's going on, can have a bit of a different treatment. But if we are suspecting that there's a big toe change or there's pain or changing the way it looks, it's important to get that checked out because it can be serious. And obviously big toes are an important part of the foot, not only for, strength and mobility, but for balance too. So if we don't have good big toe range of motion or good, movement through there, balance becomes affected as we get older, which can lead to things like falls and more serious damage.
Interesting. I guess then as well, sort of on the injury side of things, some of the common injuries that people within running tend to often end up with things like plantar fasciitis, Achilles tendonitis. Obviously, we've covered shin splints already, but those two in particular often are sort of very long and persistent injuries that people struggle to get rid of. Is there any role that podiatry could play in sort of preventing them or resolving them?
Definitely. Yes, a big one. So we'll start with plantar fasciopathy. So plantar fasciopathy is the most common thing I see in the clinic. I'd see anywhere from 6 to 8 of these cases a day. And it's the most common, client avatar. So, the most common type of client we see would be a female, age 40 to 60, who's developed pain either in their heel or their arch. And so, that's very common for both areas. Common symptoms are pain first thing in the morning. So it hurts when they get out of bed. It's stiff, it's sore, it takes a while to warm up. And say maybe by the time they've gone to the bathroom or gone to the kitchen to have a coffee, it's feeling a bit better. But then when they sit down again and get back up, it comes back. That's a really common symptom of plantar fasciopathy, and it's probably the last thing to go. So as a podiatrist, we see these every day in the clinic, and there's lots of things we can do to prevent and treat them. So we'll talk prevention first. I think is the easiest one.
Yeah.
The biggest part is making sure we are in decent shoes for what we're doing, whether that's work or running or sport, making sure we're in a shoe that is cushioned and stable and supports that plantar fascia, and to help reduce those, tensile, so stretching, and compressive, which is like pushing loads through there. Next thing we want to look at is big toe range of motion. So ideally, we should have about 70 degrees range of motion through big toe. So if you're standing up, your big toe should move 70 degrees, ideally up in terms of towards the sky. If we have decreased range through big toe when we're doing that, it just means that plantar fascia is not getting its natural stretch and not going through a thing we call windlass mechanism when we walk. So every time we take a step and the big toe extends, the plantar fascia goes through that windlass mechanism and helps that get a natural stretch. When big toe isn't moving as well, we don't get that natural stretch, and so it tightens up over time, which can lead to reduced elasticity through there, increased pain, and some thickening through there too, depending on what's going on. So we want to make sure that we've got big toe range of motion and we're in the right shoes. And overall strength is probably the next piece of the puzzle that's really important. So an easy way to test this in the clinic or at home would be doing some calf raises, single leg, 2 seconds up, 2 seconds down with good form, pushing through first and second toes. And for the average person, I'd say we aim for at least 25 of these in a row. If we can't get 25, I'd want to work on a bit of strength through that plantar fascia just to prevent future injury. And I guess the more running or sport you want to do, the more you probably strength you want to have. So maybe if you're doing marathons, you want to have maybe 30, 35, 40 single leg calf raises. If you want to walk the dog in the morning, maybe 25 would be fine for you.
Yeah, gosh. So there's a lot there, and I guess firstly you talk about getting that right fitting shoe. So in terms of maybe a running trainer or a running shoe for people who are, pounding the pavement or whatever surface they're on repeatedly, what are good signs of a fitting running shoe? What should people be looking out for? And are there any kind of red flag you've got the wrong shoe signs?
So yes, there's lots of things when we're looking at shoes, whether it's running or just pure day-to-day walking shoes. And when I was studying podiatry for 4 years, I spent that time working at what we call the Athlete's Foot, which is like a specialty shoe store here. So I spent a lot of time selling shoes, and now I deal with shoes a lot day to day. So I've had a lot of, I guess, footwear expertise over the last 14, 15 years. So when it comes to a shoe, and I've got an Asics Super Blast 2 here, it's my favorite shoe at the moment to run in. I really love this shoe. Have you run in it yourself?
Novablast.
Nova Blast, yeah, cool. Similar. Nova Blast a bit more bouncy, I reckon, but very similar, like same family. Great pairs of shoes.
I do love the Novablast. So.
Yes, Asics are coming out with a cool range at the moment. They've got the
they are
out here recently too. But in terms of footwear, so fitting tips would be making sure there's a thumb width at the front, at the toes, making sure we're not going to get too much rubbing on the toes, creating blisters, leading to bruised nails, maybe loss of toenails. The next is with the upper. We want to be able to sort of grab it like this when it's on our foot. So I should be able to grab like that. If I can't grab it and pick a bit of material up, it's probably a bit too tight. But if there's way too much movement there too, and I can grab, that whole area, it's probably too loose as well. So making sure it's the right fit. They're the big ones. And then looking at probably the heel pitch. So that's the measurement from the heel to the ball of the foot in terms of the height of the stack. So I believe the heel pitch on this one's about 8 mil. So for someone with, I guess, calf tightness, previous calf pain, maybe Achilles pain, maybe plantar fasciitis, shin pain, we kind of want to be above 6 mil heel pitch. So we want to avoid a shoe that's too minimal, where it's got no sort of heel height to it. And we want to be in a shoe that has a bit of heel pitch to reduce the strain and the loads on those areas. When it comes to red flags, I'd say Skechers, I don't love. And I get a lot of hate on TikTok for this because people love their Skechers, but I stand by it. I just don't think they're a great running shoe. I think they're a great lifestyle shoe. If you like to slip your shoes on, not tie your laces, I think they're great. But if you want to run and you want to actually do some exercise, please don't wear a Skechers. They're just not made for that. Other red flags would be just barefoot shoes. And again, I cop a lot of hate on TikTok from the barefoot running community, but I stand by it. I've just seen too many injuries from people swapping from, a really cushioned supportive shoe to a minimal shoe too quickly. And not to say you can't do it, but I would say do it over at least 12 months to make sure your foot and your shins and knees and hips and ankles and everything like that can get used to that change in load, because it's a big difference going from a really cushioned shoe with a higher stack to no cushion through there and no Achilles and calf support. It's just a big change. And what I often see is there's this, I guess, myth going around the internet that, back in the day, our ancestors didn't wear shoes. Why do I have to wear shoes? They're making my feet weak. And there was a study that came out a couple of years ago that found that if you wear barefoot shoes, there was a 7% gain in foot size, like muscle mass, which people are hanging their hats on, which is fine. I think you can, get feet stronger other ways without wearing the shoes, do some calf raises, just go for a run. That strengthens your feet. But we don't need to be barefoot to strengthen our feet. And I think the difference between us and our ancestors were we live a lot longer. So I'm currently 33. My ancestors probably died at 30. And so they didn't need to worry about foot pain, arthritis, the way the things are me when they're older. And like my nonna and my grandpa are both 86 and 87. So I've got a lot of life to think about. And I want to make sure my feet are good for that life. So there's that difference. And our ancestors weren't walking around or running around on pavement and bitumen like we are now. So myself included, I do a lot of road running. So do a lot of my clients. Back in the day, they weren't doing 100 Ks a week chasing after animals, and they were running a lot on grass too. So there's a big difference between what we're doing now and what they were doing back then. But I guess the main take home point is just be sensible about what you're doing. Like, you can do whatever you want to do, just do it smartly. Do a gradual progression to a change of shoes, whether that's dropping the heel pitch or the cushion or a minimal shoe, and build up your volume of running or, the intensity or the frequency very slowly over time. And if we can do that, we can potentially avoid a lot of issues.
No, really, really good to hear. So you want that thumbs width at the front of your trainer. You want a bit of pinch, but not too much pinch. You want a decent stack height, probably over 6 mil, and Maybe steer clear of the barefoot, definitely clear of the Skechers.
I would steer clear of both if you want to live a happy, healthy life.
I mean, happy, healthy life is, I'd assume for most people probably what they want to go for. And I guess then around kind of the fit of shoes then, obviously we've got people who run maybe more on their toes, more on their heels, different surfaces like you just mentioned. Are there any variations in what you'd maybe recommend in terms of people who are maybe more toe, more heel, or perhaps more road versus more trail?
Yeah, definitely. When it comes to foot strike and the way we move, I would say probably 80% of people heel strike, maybe 15% midfoot, and probably 4 to 5% through forefoot. So obviously a lot of heel strikers. And for those, I guess, common runners, I recommend just a bit of like a heel pitch and a bit of cushion through here if we are just striking on there. It doesn't have to be as crazy high as this. This is about 45 mil. It can be, a lot less, but just something there to absorb that shock through the heel. Same for midfoot strikers. I do recommend a bit of cushion through there, and for forefoot too. If we are a 4-foot runner, ASIC, the Waves, Sky, they recently bought out a couple of years ago. They're quite cushioned through 4-foot through there. And when I started running in them, I bought them because they look really cool. And I was like, oh, these are going to be great. They've got a bit of a carbon plate. They're light. But they just killed me because I heel strike. And so I was like, I just can't wear these shoes. They're pretty thin through the heel. And so just making sure the shoe you're buying looks like it should cushion the area you're probably going to land. And if you're not sure, I would say just buy a normal sort of running shoe with a bit of heel cushion. That'll probably hold you in good stead. But yeah, they're probably my tips for the way we strike.
Oh, good to hear. Yeah, so be sure to maybe align your cushioning with heels for heel strikers, forefoot of the shoe. And do you have any thoughts around a preferential way to hit that floor? Is obviously there used to be a lot of hype around landing at the front of your foot. Maybe more recently, it seems there's a bit more around landing on your heel, but do you have a strong position?
Not necessarily. There was a study done a few years ago that they surveyed a whole heap of runners over a 12-month period, and they found that foot strike position didn't really influence running injuries. The biggest influence of running injuries is the way we manage load. So doing too much too soon, going out too hard, making our long run from one week to the next way longer than it was before, maybe signing up for a marathon like my clients do with no real training because they can get through it. And on that point too, you can definitely grip through an event on the day. You can get through a marathon minimal training if you really put your mind to it. You're going to hurt, but you can get through it. But it's not so much about getting through that day or that event. It's about what happens afterwards. So I'll give you a really good example of this. About 3 years ago, I ran an ultra marathon. It was 70 kilometers through the hills and the highs and trail here in Adelaide, South Australia. My longest run leading up to that event was 14 kilometers. So it's obviously a very big jump from 14 kilometers to 17 kilometers. Sorry, it's 14 to 70 kilometers. Keep in mind that I'd done a few marathons beforehand, but I hadn't done one for probably 12 months. So my running volume wasn't super big at the time. I wasn't appropriate for what I was doing. But I said to myself, I think I'm going to just grit through this 70 Ks on one day and I'll just deal with the consequences after. And I can, I got through, right? But the issue with that was for 2 months, I had foot pain after that. So the extension on the top of my feet hurt, my plantar fascia hurt, my shins hurt, my ankles hurt. So just because I can get through on the day, it didn't probably outweigh paying for it for 60 days after that. And it took my body a long time to recover from that. So what I always say to clients is you can get through the day. You can do that half marathon with minimal training. But let's just think about the repercussions and how that looks to you for the next 1, 2, 3 months. Is it worth it? Or can we be a bit smarter and maybe have an event that's a bit further out than the one you're trying to do now?
I mean, that is quite a phenomenal jump up. Wow,
yeah,
I can't.
It's very dumb. Phenomenal is a nice word, but it's very dumb. And it's like everything I tell my clients not to do, I did it. So yeah, I had to pay for it, unfortunately.
I mean, everyone's gotta get the experience somehow, and I think we've all been guilty of pushing through something or the other. And actually, on that note, in terms of foot stuff, I think people can push through it for quite a while. I mean, I know I've pushed through a lot of foot stuff, and you can keep going for a while. Does that increase the damage a lot pushing through it? Does stopping sooner make a lot of difference? What's the kind of, I guess, correlation between push through time, which obviously shouldn't be done anyway, and magnitude of injury?
Yeah, so for most pathologies, injuries, conditions, if we can not push through as much and maybe seek treatment or seek help or maybe deload that area sooner is obviously better, especially when it comes to things like bony stress, second metatarsal stress fracture, navicular stress fracture. Any other areas through the feet that do cop a lot of load, they can become quite serious if we don't, I guess, see to them sooner. And it can be a lot longer recovery, which might be, go from 4 weeks off running to 6 months off running, depending on how bad it gets. And some of those areas too are quite low blood supply, and they're just more prone to becoming injured for longer. So yeah, definitely seeking treatment sooner and stopping. And kind of the rough guide we use is like the traffic light system. You might have heard of this before, being a runner yourself, where pain's out of 10 and, being your own pain scale, because you know what your pain scale is better than I do. From 0 to 3, safe to continue. It's normal pain, a bit of achiness, general soreness from running, that's okay. 4 to 5 out of 10, let's just have a think about what we're doing. Maybe have to back off load a little bit. Our body or our foot's letting us know that it's a bit too much. Anything 5 and above, so 6, 7, 8, 9 out of 10, too much, red flag. Let's just stop. There's something serious going on there. So looking at that traffic light system and using it with your own, I guess, internal rating to see if it's safe to continue. And we're looking at the pain pattern too. So whether that pain is at the start of the event or the start of the run and warms up, whether it's there at the end or how long it hangs around for afterwards. If it's hanging around for more than 24 hours after the run, I'd be having a think about what we're doing, maybe going to seek treatment. If it's, 10 minutes after the run, it goes away and we don't feel it again, probably safe to continue.
Oh, good to hear. So yeah, no lingering pain, especially over 24 hours, 5 out of 10 pain scale. That's your definite go check it out, go get something done about it. And I guess, yeah, we strayed a little bit in a good way, but back to sort of the plantar fasciitis side of things then, for people who are in the loop of it or stuck with it, what kind of actions can they be taking to sort of rehab themselves from it and keep it away?
Yeah, definitely. So there's a few things we can do at home, and I'll start with those, and I'll start what we do in the clinic. So the first thing is obviously getting into a pair of good shoes, a nice cushion shoe to take that compressive load off the heel of the arch, reduce some of that force, and a nice stable shoe with the arch support too, or a nice stable base to reduce that rolling or that foot moving too much and loading the plantar fascia. So that's the first step. The second would be a big toe stretch, so taking the big toe and just bending it up towards the sky very gently to that kind of end range. Don't have to force, don't have to jam it, but just where it feels comfortable, and holding that stretch for 30 seconds. Try and do that 3 times a day, morning and nighttime, just to get a bit of stretch through the plantar fascia. And then working through any areas that might be tight, rolling like a trigger massage ball through the arch, through the calf, maybe foam rolling massage gun, loosening up those tighter areas of fascia and muscle that do contribute to foot pain. So I do those things at home. For most people, that can definitely help. And then if pain still persists, we can look at taping the foot. We just want to do basically a tape that supports the arch, takes pressure off the plantar fascia. There are lots of good YouTube videos out there that you can just use and follow that. I would do that too for a few days, see if that helps reduce pain. If we're finding that those few things don't help reduce pain, we're still getting pain first thing in the morning, it hurts to walk, it's not getting better, I would go and see a podiatrist. So you can get a full assessment obviously done. We're looking at, the way the foot posture is, what shoes we're wearing, why that pain might be occurring, and they can do hands-on treatment. So a big part of what we do in the clinic for plantar fasciopathy is what they call shockwave therapy. You will probably have that in the UK. What that is, it's a little, gun apparatus, and that emits a vibration. What that vibration does goes through the plantar fascia, through the tissue, opens up the capillaries, promotes blood flow, helps reduce inflammation, reduce calcification, reduce thickness of the plantar fascia, and start that healing process. So we normally do that once a week for 6 weeks. And I would say most people see about 80% reduction in pain over that 6 weeks. So we couple that with taping, footwear education, custom orthotics, so they do need that. And if we can do those things over that period of time, pain goes down. And then we look at strengthening that plantar fascia up with things like calf raises, intrinsic foot exercises, big toe exercises, balance exercises, to make sure when we go back to walking, running, whatever the activity was, that plantar fascia is strong enough to handle that load and do more than we did before.
Oh, interesting. And interesting you mentioned shockwave there, because actually a past guest, Charlotte Alexander, if anyone's listened to that episode, had, someone who had repeated plantar fasciitis issues. And I know many other people, and people do talk about shockwave being that kind of magic fix almost. And how does that differ to ultrasound then? And what exactly does it do in terms of, I guess you talk about sort of breaking things down, but is that what causes the issue in the first place, or?
I think it depends on the reason the person is getting plantar fasciopathy. So whether it's acute, so within that first kind of 6 weeks it started, or whether it's chronic, so over 6 weeks. There's really good evidence in terms of research and studies for plantar fasciopathy, for chronic plantar fasciopathy. So over 6 weeks, it helps obviously break down calcification of the fascia. reduce thickening, promote blood flow, help sort of stimulate the body's own healing response that hasn't quite done it itself through that fascia. It does still work in acute phases. Say, for example, a client might have gone for a big run on the weekend, a bit longer than they normally do. They come in Monday morning, plantar fascia is irritated, there's a bit of swelling. It still will help with that, but the research is around all the chronic stuff. And so I think where it differs from ultrasound, obviously a bit of a different mechanism, but basically everything we do in the clinic as podiatrists or to heal the body promotes blood flow. So blood obviously has oxygen, nutrients, all the good stuff we need to heal and repair tissue. The difference between ultrasound and shockwave is the mechanism, the way it's done. And there's a bit more research for shockwave and it being, I guess, successful compared to ultrasound. Ultrasound works for some people, but I would say it's a bit more hit and miss than shockwave is. So we tend to go with shockwave now more often because we just see more success with it.
Oh, that's really good to hear. So if you're in a position where you are picking between the two, maybe do steer more towards the shockwave side of things. And then I guess in terms of Achilles tendonitis, another very common one, what's the situation with that? You know, what's going on there and why is it such an issue for so many runners?
Yeah, so I guess again depends on what's happening with the Achilles. So there's a few different pathologies in terms of Achilles tendons, whether that's true Achilles tendinopathy, where the tendon is not handling the load being put through it, it's irritated, it's sore, it's grumpy, it's stiff in the mornings, it hurts to exercise. Whether that's swelling of the tendon sheath, so we call a paratendonitis. So the tendon itself is actually pretty good, but the sheath around it gets irritated. So every time that sheath or that tendon moves against the sheath, that just hurts. With a paratendinopathy, it doesn't warm up, where an Achilles tendinopathy will. You kind of run, it gets a bit better, feels pretty good when we're moving, and then when we cool down, it hurts again. With the paratendinopathy, there's no warm-up, cool-down effect. It just hurts all the time, and the more we do it, the worse it gets. There can also be retrocalcaneal bursitis, so like the bursa sac in between the Achilles and the heel bone gets irritated from that friction as we move, and the Achilles tendon itself is fine, or there can be what we call insertional Achilles tendinopathy, so where it attaches to the heel bone, there can be spurring and fasciopathy, irritation through there. So there are a few things that happen through the Achilles tendon, which is why it's important to get the correct diagnosis. And a good example I'll give for you with this is because the rehab and the way we treat it does change depending on what's happening. So for example, a tendinopathy versus a paratendinopathy, with a tendinopathy, we'll load that. So the tendon likes being loaded, whether that's calf raises, hops, whatever it might be for that person, depending on where they're kind of at in their rehab journey. Whereas for a paratendinopathy, we don't load that at all. It needs to rest for the inflammation to go down. So we'll do things like anti-inflammatory night wraps, we'll ice it, we'll do corticosteroid injections, we'll do other things to make that swelling go down, but we won't load it till it's gone down because all the loading we'll do is irritate that sheath again and make it swell back up. So yeah, it's important to get the correct diagnosis because what I'll often see is clients think they've got Achilles tendinopathy. And so I'll be like, I've been doing calf raises every day at home. You know, I've seen the physio, I've seen whoever it might be, I've been on YouTube and it's just not getting better. And then we look at what's going on, we look at the swelling, we look at what irritates it. And we found that, you know, doing the calf raise or loading it the way they are is the thing irritating. So we've got to stop doing that. And within 2 weeks, that swelling's calmed down and we can actually load it back up safely. So it's important to get a correct diagnosis. Otherwise, we kind of go around in circles with the rehab and we can be doing the wrong thing that keeps the pain around for longer.
Oh, that's really interesting. I think I've probably been someone who's been in that camp of assuming it's the first when actually it's the latter. And yeah, you do the calf raise and the more you do, the worse it gets. You're like, this doesn't feel right. So
yeah, it's like I tried all the stuff and it's not getting better. I did the calf raises. I've been doing calf raises for 3 months. It's not better. And I'm like, yeah, it's not Achilles tendinopathy.
Gosh, it's interesting, you know, just small subtle differences, something that can initially present as, oh, it must be this. Actually, there's two different versions of it. And you spoke there about sort of some kind of night wraps and steroid injections. What's kind of involved in a night anti-inflammatory wrap, and what are your views around steroid injections? You know, what are the sort of risks, benefits, who should they be for?
Mm-hmm. So we'll talk night wraps first. So with something like a paratendinopathy or a swelling of the Achilles sheath, we'll use a combination of Voltaren and what we call a hiridoid. They're both anti-inflammatories, work slightly differently. And it sounds really dumb, but we'll put that on the Achilles and we'll glad wrap it at night, normally for 14 days. And that heat staying in with the glad wrap overnight helps that swelling in the Achilles tendon sheath to come down. So obviously I'm not getting the rubbing and the friction of the tendon, which means we can do more without pain. So it's a good place to start if you are having that type of Achilles pain. But again, be very careful because some people can't tolerate anti-inflammatories. You know, whether they've got other medical conditions going on, it's not the right thing for them. So I think if you are going to try that, go and see your doctor first, go and see someone who is able to give you that proper education and make sure it's safe to you. Don't just go whacking on the first anti-inflammatory you find. When it comes to corticosteroid injections, I do them myself personally. So I've done some extra study outside of university, which we call in Australia here, it's called endorsement for scheduled medicines, which means I can prescribe schedule 2, 3, 4, and 8 medicines. And some of that includes corticosteroid injections. Now, there are some, risks with corticosteroid injections. We want to make sure we're doing it safely and we're not just whacking it into where we think it should be, but it's not quite in the right anatomy. So a lot of the time we'll do it under guided ultrasound. So we use a handheld ultrasound to make sure it's going in the right spot. And we've got to be really careful around tendons, especially because it can weaken the tendon. So I don't do any injection into the Achilles tendon itself. I do a lot to retrocalc bursa because that is a very pinpoint area we can get it in very easily through ultrasound, and it has a really good effect without being too close to the tendon. But if we're going to inject around the tendon, we need to be really careful because it can lead to weakness and potential rupture. So there's a couple of things that happen with Achilles tendons when we cortisone around them. The first being pain reduces. So the person feels really good. So like, I'm going to go for a run. I'm going to go do the gym and do some jumping. And they do a bit too much because the pain has gone away, not knowing the tendon is still in that weakened state. It just feels like it's gone because the pain's been masked. So they go back to their normal load and the tendon ruptures. And there's a very extensive rehab to get that back, up to 12 months some people. So we want to avoid that if possible. The second thing with corticosteroid injections is, depending on your age, body type, other medical conditions, not everyone is safe to have those. So we've got to make sure that, things like we're not pregnant, we don't have uncontrolled diabetes, we don't have uncontrolled blood pressure, those kind of things, to make sure that we're not going to hurt that person in another way from giving them corticosteroid injection. So again, they're not for everyone. They don't always work as well. It can be very hit and miss depending on the person. Some people have one and they're good to go forever. They never need another one. Other people have one and within 2 days, the pain's back again and hasn't worked. So it depends on how your body, metabolizes and accepts the cortisone. So they're not for everyone. And I would recommend, again, going to see a professional if you are thinking of getting one, just making sure it's safe and the right thing for you. A lot of the time too, we can avoid not getting on with doing the right thing. So changing shoes, loading the tendon properly, reducing the activities that are aggravating. We don't always need to go down the corticosteroid injection path, but if we are, let's make sure we're doing it safely.
Yeah, no, definitely. It sounds like something, I don't know, maybe it's just the name, but it sounds like something that's a bit scary, and it is something that people sometimes think about as a last resort, but definitely does sound like, for sure, something to be checked out with, another medical professional to make sure that your actual health can support that. And I guess in terms of the night wraps there, you mentioned kind of the heat component of it. Often I feel like there's a lot of push for sort of icing an injury, and people are kind of immediately pushed towards, get those peas out the freezer, get that ice on there, shove it in a nice bucket. Is that actually the right approach, or, is it heat that people should be reaching for?
Yeah, it depends on what the injury is and kind of when you are where you are in the healing cycle. So what we call acute, say for example, you roll your ankle and that's 24, 48, 72 hours afterwards. You want to put a bit of ice on there to help that inflammation calm down. After that time, it's probably not going to help that much unless you re-aggravate it. Say you tweak it when you're walking and running again, and we want to try heat after that period of time. For something like an Achilles, you can use ice as like a first port of call if you don't have access to anti-inflammatories. That will definitely help. But it's hard to put ice on your Achilles all night because after, say an hour, it's not cold anymore. So the anti-inflammatories help it have that effect longer than, say, an ice pack, which will go cold, after an hour. So go warm after an hour.
Yeah, for sure. No, interesting to hear. And I guess then we kind of, covered around sort of injuries, a bit around sort of footwear and foot choice. Let's move on to sort of general foot health and, for your average runner and also your maybe higher end runners, perhaps sub-elite and elite, especially sort of female runners in particular. What are general things that people can be doing? Is there a sort of foot care routine or specific things that you'd sort of recommend?
There's definitely things I'd recommend. When it comes to foot health, I think the main thing is making sure we've got good mobility and strength. So making sure we are taking our feet through range of motion, warming up, cooling down, that sort of thing, and making sure we've got adequate strength for the activity we're doing. So for example, moving from a 5K park run to a marathon, obviously very different distance and requires different mobility and strength. So making sure we do have this strength to go through there. Do you do much with just checking your feet day to day and seeing if there's any physical change or the way they're moving has changed as a runner yourself?
Personally, no, not at all. Not giving it a thought really.
Yeah, cool. So we do a thing here called toe mojo, which is a bit of a funny name. So basically making sure there's three movements. The first being making sure you can spread your toes. We've got that dexterity to be able to move. The second being if feet are flat, we can move big toes up while keeping other toes on the ground. And then we swap that to moving other toes up while keeping big toes down, okay? Having that dexterity through the foot means we can balance better, we have better proprioception, and we're less likely to do an injury, whether it's plantar fascia, intrinsic muscles, maybe rolling our ankle, than if we don't have that mobility. So make sure we've got good mobility through there, which is where I guess, my argument against barefoot shoes comes into. We can get that without having to go buy a $200 pair of barefoot shoes. We can just do the movements right. So make sure we've got that dexterity in that movement. So they're the tips I follow for good foot health. And again, just making sure you're in the right shoes is a big one. Probably one of the biggest things I see as a podiatrist is people's in the wrong shoe for their activity, whether they're running, a marathon or attempting to train for a marathon in a really old, worn out pair of shoes, doesn't have any support, doesn't have the cushioning through there anymore, or whether they're, in working on their feet 12 hours a day in like a really inappropriate pair of shoes. So making sure we've got the right shoe on is one of the biggest things we can pull, the biggest keys we can pull to prevent foot pain and make sure our feet stay healthy as well. And if there are any changes, so for example, you notice big toe joint getting bigger, maybe feet flattening out, getting blisters, callus areas you didn't normally used to get them, or shoes don't fit the way they used to, worth getting checked out because there can be other stuff going on in terms of body. That means feet are changing and we need to maybe change our approach.
Interesting. I mean, as you were sort of going through that there, I was, just moving my feet a bit under the table. And to be honest, I'm not entirely sure I can really spread out my toes or lift my big toe off without the other toes coming off the ground. So I'm sure I'm not alone there. If someone's unable to do that, then what kind of ways can they increase that mobility or range of motion?
Yeah, I would think just first of all, just practice. Like I really struggle with this myself, and most people do because it's not a movement we know how to do. It's almost like a bit of a Jedi mind trick where I'm looking at my foot trying to move my toes, but they're not moving the way I want them to. And it takes a bit of time to get that kind of mind-body connection with our feet because they're so far away from our brain and our head. So the first thing we practice and just start small, like even just start trying to, holding down lesser toes or the other 4 toes and just moving big toe up and down, getting used to like just that isolation, then swap, just hold big toe down, get used to moving the others. Then over time, try to hold them down less and get that dexterity. Other things you can do are just doing some calf raises, going up and getting some gentle stretch through those toes. Practice moving the big toe itself, so pulling it out, lifting up with hands, taking it through range of motion, just getting it used to moving maybe a bit differently than it has been before.
Oh, good to hear. And it really sounds like calf raises are a bit of a holy grail. Why is that? Why are they so pivotal?
They're just such good bang for buck. Like if you want to pick one exercise for foot, ankle, lower leg strength, just do a good calf raise for reps. I think the beauty is, one, you don't need anything to do them. You can just do them body weight at home, barefoot. You don't need any equipment or weight or spend any money. But they've got such good progressions and regressions if you are injured or you want to get stronger. So, if you can't do a single leg calf raise, we can start with a double. We can start with seated. We can start with other variations. As we progress, we can go from, double to single to maybe single with a hold at the top, maybe slower tempo. Maybe we can start adding body weight, aim for maybe 20% extra body weight through reps. There's just variations we can do through a calf raise and we get a lot of bang for buck. And the beauty of a calf raise is it does a lot in terms of strengthening the areas we want to strengthen. So plantar fascia, Achilles, calf, it works big toe joint, it works the foot intrinsic muscles. So it's a good bang for buck exercise that costs nothing. I can get a lot of value from.
Gosh, well, everyone get on the calf raises, stay on the calf raises. It's not just a physio's go-to. There's clearly a lot of benefit going on there. And in terms of doing then a really good calf raise, have you got any maybe 3 top tips or pointers for people?
Mm-hmm. Yes, definitely. So first tip would be making sure we're pushing through first and second toe. Some people tend to roll off the side and maybe not recruit the right areas we're meant to. So big toe, the thicker, flatter, stronger toe is meant to be pushed off. Just making sure we're pushing off first and second toe for good form. Second would be to make sure we're not just using momentum, like just bouncing, taking it through a slower range of motion, maybe 2 seconds up, 2 seconds down, so we're not bouncing through there. And the third would be making sure we're not using our knee. So what can often happen as we get fatigued is we start to bend knee rather than bend ankle and bend foot, and we tend to use quad more. So making sure we're keeping our knee stable, whether that's completely straight for some people, a bit of bend, as long as we're keeping it in the same position and just using the foot to move up and down. So to go through those again, pushing through first and second toe, not using momentum and bouncing, using a good tempo, and not using knee to, use quad and recruit other muscles through there.
Brilliant. I mean, I won't repeat them because you've summarized them already. But no, super useful tips there. So I hope everyone had notes out for that. In terms of, I guess, then with calf raises, in terms of if people are doing them off maybe a stair or something like that, how far on the stair should their foot be? Should they kind of be, falling off, gripping with their toes, or should they be perhaps almost close to the mid of their foot that's still on the stair?
I think depends on foot type, age, foot length, and maybe what injury they're coming with. So for example, if they're trying to strengthen Achilles tendon, but they've got a bit of a big toe issue too, maybe leaning or landing right in the big toe joint is going to be a bit too much for them. Maybe they want to go more towards midfoot. If they don't have that injury, they might want to go and make it a bit harder and go towards the forefoot on the step. So I think it just depends how far you want to go down to. Obviously with the midfoot, we get a bit less range of motion, whereas compared to foot, we get that extra stretch and extra weight through the bottom there. So I normally say to start in kind of middle of the foot, around the middle to the ball. So say, for example, here, and see if that feels comfortable, and then try and progress a little bit further back with, the foot off the step a little bit further, just so we're using mainly just ball of foot and not midfoot.
Okay, no, interesting to hear for sure. And I guess then as well, you mentioned about potentially people having changes in their foot, some other causes. What sort of reasons could that be? And for someone who's running a lot, could the way they're running have an impact on that potentially?
Yeah, definitely. I think foot changes, look, everything with podiatry has a range of reasons it happens, and it depends on the person, depends on a lot of the time genetics too. So genetics play a really strong role in the way your feet look and the way they change over time too. So the biggest predictor of getting a bunion is your grandparents have a bunion and you just inherit their genetics. Because unfortunately, for better or for worse, we tend to move like our parents. So we tend to develop foot issues similar to them if we don't do the right thing. So genetics is a big one. Rapid weight gain, for example, pregnancy. Obviously, we see a big increase in weight over that 8 to 9 months. And that can be a lot for the foot to handle. We see flattening too, ligament laxity, feet flatten out. They don't necessarily get longer, although people do go up a shoe size because their foot just got a bit wider, and there can be swelling and things like that too. In terms of training, there are other things that do change the way, I guess, feet are shaped, whether it's running in a poor pair of shoes for a long period of time. And say, for example, we are a bit predisposed to getting a bunion, that can just speed that process up a bit more than, say, the average person, or whether the shoe is a bit too tight as well. The shoe is a bit too tight. Our foot's expanding a bit when we run because there's blood flow going through there, and that tightness is compressing that big toe area and causing that toe just to deviate. And again, bunions, you've got to be a bit predisposed to them, but again, it can just speed up that process a bit more. So I think if you notice your feet are changing, whether that's purely the way they look or the way they feel, or there's pain happening, I would go get it checked out, because it can be that there are other things going on, and can do a lot to prevent future pain or future issues for you.
Yeah, and pain-free is the goal. That's definitely where everyone wants to be. And actually, before we, I guess, move towards sort of the close off, bunions, you've mentioned it a few times, and that is something that can impact so many runners. And I know some people who struggle with getting shoes that fit because of it. What would you say to those people, and what sort of things can be done to alleviate the issues with them?
Yeah, it's really tricky. And again, it depends on the stage of the bunions. There are 4 stages, and from 1 to 4, 1 is just a little bit of change in deformity, and 4 is like a really deformed going under the second toes, joint becomes really stiff. So what happens with the bunion is obviously develops over time, and moving from a stage 1 to a stage 4 means normally we get reduced range of motion through big toe. The toe starts to drift over towards the other toes and can become painful. So if we're someone who is noticing a bit of a change, early prevention is the best thing we can do for it, whether that's getting a wider pair of shoes, getting a more supportive pair of shoe, or the gold standard for preventing a bunion is getting a pair of custom orthotics. So made for your foot that take pressure off that bunion, help disperse pressure elsewhere, which means we're not going to go back to the bunion being straight, but we're not going to get any worse. We'll just stay the way it is. And for most people, that's a pretty good win. It's going to stay the way it is, and there's not going to be any pain. As we start to progress further through that journey, and we get to say a stage 3 or a stage 4 where the joint's really deformed, it can be really hard, like you said, to find shoes that fit. It becomes really uncomfortable depending on the way that foot or the way that big toe is and the way it looks. If we do get to a stage 4 and, we're not fitting in shoes, we're getting blisters because shoes are rubbing, it's becoming painful all the time, we do probably need to go down the surgery path for some people, where they go and get that straightened. And what that means is they go in there with keyhole, at least here in Adelaide we use keyhole surgery. They shave a bit of that extra or deformed bone off. They straighten the toe and they pin it with 2 pins to make sure it's not going to come back in the future. After that period, we go into what they call a post-op shoe, so a stiff sole medical shoe, 3 weeks, And then we normally go into a sneaker for 3 or 4 weeks, and we're pretty good to go again. So we obviously wouldn't want to not get to the surgery stage if we see it changing. And a big predictor is like, look at your mum and dad's feet, your grandparents' feet. If they've got it and yours is changing, that could be how it looks for you in the future. So it's good to get early intervention to make sure we're not going down that path. And I think for most people, we can avoid surgery. I send for maybe a handful of bunion surgeries a year, and I see a lot of this stuff day to day. And it's because the person's sick of the way it looks, they're sick of it not fitting in shoes, or it just hurts every day and we can't get pain to go down. If we're not quite there yet, there's probably no reason to get pain, no reason to go get surgery. We can get away with a better pair of shoes and a pair of custom orthotics.
No, really good to hear. And yeah, definitely, if you do notice any sort of deformity there, you know, you think you might be in a stage 1 case, for sure, that is something that, yeah, best nipped in the bud ASAP by the sounds of it. But no, Joe, thank you so much. You know, we've covered a lot today. I think a lot of value that listeners can take away from this episode, a lot of things that people can think about and work on. And so just a few questions to close off with then. What is maybe one question that you wish you were asked more by your patients?
That's a really good question. The one that comes to mind is, I wish they'd asked me if they could do the event before they do it. So do I have the strength? Have I trained enough? You know, is this going to hurt me for a long period of time? I'd like to hear that before I see their Strava or see their photo on Instagram of them doing the event and thinking, we didn't quite have load management for that. And then they're going to come and see me next week because everything's sore. So probably number one. But probably I think one of the biggest things for podiatry in general is just, I guess, more awareness about what we do. You know, we don't just cut toenails, we don't just debride corns and callus, treat plantar warts, and we do that stuff, right? But we do a lot more. We're the specialists for foot, ankle, and lower limb pain. So the question I wish I got asked more is, can you help me with this? Because a lot of the time we can. People think that maybe I've got to go to a physio or go to a chiropractor, go to an osteopath, depending on what it is. But podiatrists can do a lot more than people think they can. And I think it's on us as podiatrists too to get a more awareness around what we do and better education to be able to educate the population that we are the specialists in this kind of stuff, and we can do a lot to help foot pain.
Absolutely. I mean, knee down, you know where to go, guys. And hopefully this helps a little bit on that journey. And I suppose a follow up on that one then, what's the most niche, I guess, ailment or pain that you've sort of solved for someone through podiatry?
The most niche? That's a very good question. The most niche, because like obviously, 95% of what I see is like plantar fasciopathy, Achilles pain, shin splints, metatarsal stress fracture, like really common big toe injuries, really common pathologies. The most niche. Oh, this is a gross one, and it wasn't sport related, but one time a client came in, he was an older gentleman, he came into the clinic and he said, I've just got this pain between my little toe and my fourth toe, and it's just not going away. I've tried to have a look in there. I've tried changing shoes. It's just not getting better. And I looked in there and there was a cashew in between his toe that had been in there for like a peanut. We've kept the cashew, like a nut that had been there for weeks. And it was rubbing and irritating and causing a wound in there. And I was like, yeah, okay, there's a cashew between your toes, mate. So we're going to take this out. I'm going to dress this wound today for you. He was like, oh, great. I was like, it's probably not a footwear issue. It's probably we're just going to not step on nuts around the house. Would be good. So not really a sporting or running related one, but just a bit of a niche, weird one.
That is incredibly niche. I don't know what I was expecting, but it was definitely not that. I mean, did he just not take his shoes off or just...
The thing with, so we're going to delve into another realm podiatry, but there's obviously, diabetes, type 2 diabetes is a thing. And as we get older with uncontrolled diabetes, we get what they call neuropathies. We can't feel our feet as well. And so a lot of the time people will get numb feet. And so they'll step on things, cashews, sharp objects, glass, and not feel it necessarily until they see a bit of blood on the carpet or they check their foot for something else. A client I had really early on in my career, he came to the clinic. Because I've got this pain in my foot. It only hurts when I wear my work boots. I was like, that's weird. Anyway, looked at his foot and there was a bit of like a red mark. And I was like, that's a bit weird. Checked his work boot and there was a nail through the sole which was pointing into the shoe. Because he had diabetes, he couldn't feel the nails. Every time he put his boot on, he'd step on it. But he couldn't really feel it. But he noticed there was a thing on his foot every time after he worked. And so there's a lot of that if your diabetes is uncontrolled for many years when you're older. And so, yeah, we see a bit of that stuff every now and then.
Gosh, wow. Gosh, yeah, the whole realm of things. And yeah, that's the thing, small things that people might not realize are related. It's funny how, connected everything can be. Okay. And For you, what's something cool that you learned recently or that's kind of captured your attention, maybe in the area of sport and podiatry?
Something cool I've learned recently. I like to think that I'm always learning new things. And the beauty of podiatry is like, there's always new running shoes that come out. There's always extra study we can do. There's new research papers that come out. Something cool I've done recently, though, is my endorsement of scheduled medicine. So being able to prescribe medication using things like cortisone injections, anti-inflammatories, inhaled analgesic, green mist for surgeries, that kind of stuff. It's just helped me have a bit more of a well-rounded clinical practice. And I can refer to GPs a lot less, which means, here in Australia, at least, there's pretty big waiting times to see a doctor. It might be, 2, 3, 4 weeks. And if you've got a sore foot and you're waiting to see a GP before I can do something with you, like it's just a bit of a pain to do that. And so being able to give them the medication or give them the injection there and then just speeds up their whole rehab journey and just leads to a better, well-rounded, podiatry practice for myself, which has been great.
Oh, no, awesome. Yeah, that is really cool. And yeah, I can't say waiting times are any better here, really, but all around the globe crisis. Okay, and final question for you, number one holiday destination?
Oh, I want to go back to Italy. So I've been there before. I went there pre-COVID, I think it was 2018, but I went with my family, so my siblings and my mum, and we went. It was great, but we did it on like an over 50s tour. Mum was over 50. So like me and my siblings were there, obviously, but it was like us and a heap of old people. So I'd love to go back. Not that it was bad, like they were fine. I'd love to go back and do it again, like with my wife. Like a bit of a different holiday. So yeah, Italy, we've got family from there, and my grandparents come from there. So I'd love to go back there and see where they were growing up again, and eat the food and drink the wine and just have a nice time. What about yourself?
Oh, no, that sounds like a great one. To be honest, I'd probably say, it'd be somewhere in the Alps, probably. So Europe, maybe Switzerland. I quite like it, but just quite pricey too.
Yeah, well, at least it's a lot closer for you. So you can go over there on a weekend. It takes a bit more effort from here.
I was going to say that's a whole, I don't know, 24 hours, is it, or something crazy?
Yeah, it's pretty long. It's pretty long about that, yeah.
Yeah. So when you want to lose a day of your life, you can decide.
Well, yeah, you've got to go for a few weeks if you're going to go to make it worth it. Yeah.
Yeah. I've been to Australia before, actually. A lovely, lovely country.
Beautiful. We actually had a pod from the UK start this week. He's from London, but from Sheffield originally. And yeah, he's loving it because of warm weather here. The sun's out. So he's like loving it. Very different to the UK, I'm assuming, at the moment. Yeah, if you're ever here in Australia again, if you're in Adelaide, come and see our clinics. We'll do a running assessment, chuck you on the treadmill.
Oh, awesome. Thank you. Great. Well, no, thank you so much for coming on, Joe. It's been, fantastic to have your expertise, your enthusiasm. You're clearly passionate and good at what you do. And loads of stuff that people can take away from this episode. And for anyone who is based in Australia and maybe interested in coming to see your clinic, where can they find you? How can they reach you? What's the process for that? And do you want to share any sort of things around that?
Yeah, so our clinic is PodFit Podiatry here in Adelaide, South Australia. We've got 3 clinics at the moment, one in Modbury, Findon and Glenelg, which are suburbs here. So we're a predominantly MSK and sports clinic. So we'd see probably 70% sporting MSK running injuries and 30% skin, nails, other things like that. So if you're in Adelaide, we have foot pain, feel free to come and see us. If you're online too, we do online consults through telehealth. So let us know, we can book those in and help you out. And if you want to, keep up to date with what I'm doing, for Instagram, it's just Joe Keain Podiatrist, spelled JoeKeain, Podiatrist, PODIATRIST, is my handle, and same for TikTok. So I post a lot of running, footwear, foot pain content on there. So if you'd like to follow me, feel free to reach out, send me a DM. Always happy to help where I can, and I love doing what I do and really like doing this.
So that's it for today.
Again,
thanks for listening. I hope you enjoyed today's episode.
No, my pleasure.
If you did, be sure to rate, subscribe, and leave a review. This really helps to get the content out there.
Thank you so much.
And I want to make this podcast the best possible for you. So go follow Fitter, Faster, Happier on Instagram. That's Fitter, Faster, Happier to leave your questions, comments, and feedback, and for updates and guest requests. All the best for the week ahead, guys. Run happy, live happy, be happy.